Bioterrorism, Epidemiology, and Environmental Emergencies. So our objectives are to discuss some concepts of epidemiology, to discuss the signs and symptoms and treatments for various biologic and chemical agents, and discuss the signs and symptoms and treatments for various environmental emergencies. So epidemiology, there's some terminology that you might hear when we talk about epidemiology, and one thing is the term endemic. Endemic means the constant presence of specific diseases or injuries within a specific geographical area, the usual frequency. So the flu is endemic to the Northeast during the winter months. Epidemic is where the occurrence of a disease or condition, a usual endemic disease or condition, but at a much higher rate and level than we normally see in this specific population. So we could have a flu epidemic where we have flu at the normal time of year, the normal geographic area, but at a much higher rate than what we were anticipating. So it could cause a strain on the resources that we have available. And then we have the pandemic, which I used to talk about kind of in theoretical terms back a few years ago in the 2019 to 2020 era. And that's where a usually recurring disease process or something new and unusual is impacting huge amounts of the world's population. So when we have an epidemiological issue, when we're presented with that, say if we work in a walk-in clinic or an emergency room, we have to look at who is that affected person, where that person is living or has been recently in terms of maybe some travel, and when that person was affected, because that can help us determine if this is something a usual occurrence or something very unusual. So let's look at bioterrorism, the intentional use of microorganisms or toxins derived from living organisms to produce death, disease, panic, fear, disruption in society. So there are various levels of biologic categories, but all of them will have certain clues that we can address and analyze when we are presented. So, for example, an increase in similar or unusual syndromes, an unusual age or population distribution. So say you have a bunch of adults coming into your emergency room or walk-in clinic or doctor's office with what looks like the chicken pox. But that's not usually something that is seen in adults. It's seen primarily in children, and with the chickenpox varicella vaccine isn't really even seen that much anymore. But all of a sudden you've got a whole bunch of people presenting with chickenpox-like lesions. The red flag should start going off and say, could this be a smallpox bioterrorist attack? An increase in unexplained disease or death. So conditions that appear to be like the flu, the regular kind of flu, upper respiratory GI bugs that can occur, but massive numbers of people dying from what is usually kind of a self-limiting, oh, you get it, you get over it. And maybe only those people with a lot of comorbidities end up being hospitalized and dying from these diseases. Or an atypical transmission route. So, for example, something like anthrax or botulism, which can be can be used as a bioterrorist agent and attack people in atypical routes. For example, inhalation anthrax. Anthrax is not usually something that you breathe in. You usually get it through your lesions or cuts and exposure to the spores that are in the ground. So farmers and cattle would get them. Or botulism that is aerosolized. Botulism is usually in food that you ingest and is and gives you that that infection. So the CDC has categorized potential bioterrorist agents as category A, B, or C. And this link here is gives you like kind of a one-page list of what they consider as A, B, or C. And the most dangerous ones are what they consider the category A agents. And those would be anthrax, botulism, plague, smallpox, tularemia, and viral hemorrhagic fevers such as Ebola and Lassa virus. And they're categorized as category A because they're easily disseminated within a wider population. They're highly infectious. They cause high morbidity and mortality and have a high level of person-to-person transmission once that patient is exposed. They can be difficult to diagnose and treat. They cause panic and social disruption, and they could have been used in the past as bioweapons. So all of these agents can cause flu-like symptoms, so it's your responsibility as the nurse to identify what is unusual about this particular infection. Is it an unusual population, distribution, location, that sort of thing? Because many times they do present with flu-like illnesses, coughs or pneumonias, skin ulcers, rashes, diarrhea and vomiting. So a lot of these can mimic common illnesses that your patients might be encountering just in their everyday-to-day situations. Now, when we talk about pandemics, as I said, I used to talk theoretically about these, but COVID-19 kind of brought it all to the forefront because in order for a pandemic to occur, three conditions must be met. It must be a new, highly pathogenic virus, check. Genetically unique, check. Easily transmitted from person to person, check. There's your COVID-19. And our areas of concern were very, very similar to what we encountered when we had an actual pandemic in 2019, 2020, 2021. The availability of vaccines. It can take, or it used to take, 6 to 9 months and to develop a vaccine and 3 to 5 years to produce enough for the population to be vaccinated. But things were expedited and developed very, very quickly. The effectiveness of antivirals. In some cases, they were effective for patients with COVID-19. In other cases, they were not, depending on the amounts of comorbidities that patients had. And then the shortages of resources. And that's kind of a no-brainer. We all knew about it, the shortages of gloves and masks and gowns and all kinds of, ventilators. Again, I used to talk about this theoretically, about how of the current available beds and ventilators, a peak pandemic week would require double the number of ICU beds, of ventilators, that sort of thing. And we saw that in real life during the COVID vaccine epidemic. So let's talk about first aid for common emergencies. There is a very good link here for the Mayo Clinic. It gives a lot of information about various environmental conditions that can occur and how we treat them. It's worded and developed for laymen to understand and be able to put into effect, but it is a very good link. So when we look at frostbite, we need to think of who would be at risk for developing frostbite. Those people who have poor circulation, Raynaud's disease, smokers, peripheral arterial and peripheral venous disorders. So initially what we have with frostbite is pain, numbness, and pallor, and then it can go through various degrees where we develop blisters, and then we develop edema, and then we can end up with losing that particular body part. So we need to rewarm that body part as quickly as we possibly can. So when we're out in the environment, we can use body heat to warm up that extremity. And then we have to, when we get them to the facility, rewarm them very, very rapidly, which can be very painful. We don't want to rub or apply dry heat, which could produce any further injury. And then possibly if necrotic tissue develops, we may have to do debridement or even amputation. So here is somebody in very early stage, probably in the second degree frostbite stage with blisters and edema, and you can tell that at some point these can burst and cause necrotic tissue. Heat exhaustion. We're going to talk about heat exhaustion and heat stroke kind of together. So heat exhaustion can be caused by dehydration. Patients are out running in hot weather and they're perspiring a lot and they're not getting good fluid and electrolytes during that. With heat exhaustion, the patient has normal mental status but may develop some flu-like symptoms, may have some hypotension and increased heart rate, some tachycardia, and so we need to stop their activity, get them into a cool place, and there is not an increase in core body temperature when a person has heat exhaustion. However, when we get to heat stroke, that can come on very, very suddenly, or it can come as a result of not treating these signs and symptoms of early heat exhaustion. In this case, patients do have an altered mental status, elevated body temperature over 105 degrees possibly, anxiety, confusion, hypotension, tachycardia, tachypnea, and can devolve into renal failure or DIC. This patient has to be cooled down very, very rapidly. We need to ensure that they have a patent airway. We need to prevent seizures. So the mortality rate for heat stroke is very, very high, 80% if individuals are not treated in a timely manner. Hypothermia is where the core body temperature goes below 95. So that is the definition of hypothermia. Now, sometimes you can say, oh, someone is hypothermic if they're just cold. But true hypothermia is a core body temperature less than 95 degrees. And it can go, as it goes lower and lower, gets more and more serious. Patients will lose consciousness. Shivering, which you will see at the beginning of hypothermia, will stop. The patient, it can't even shiver anymore. Their body temperature has gone so low. We need to rewarm them as quickly as possible. So we want to give them warm IVs, warm gastric lavage, warm humidified oxygen. That gets into the core of their body. Until we can do that, warming blankets will be very helpful as well. Insect bites and stings, we have to be looking for anaphylaxis. So we need to get them to the emergency room if they start having trouble breathing. We need to treat them with epinephrine. We need to remove stingers. We do that by scraping them out, not trying to pull them out, because if we try to pull them out, we can actually break off the stinger, leave the barb in the patient's skin, and then that poison is still releasing and causing more problems. So we need to scrape it out in the opposite direction from where the angle is of the stinger, and then get them to an emergency room so that we can provide respiratory support if needed. Snake bites. We need to keep the extremity below the level of the heart. We need to keep it as immobile as possible to prevent a lot of circulation and the venom getting to the core circulation. If we can identify the snake, that's great, because then we can identify what antivenom we could use. The important thing is to get them to the hospital and immobilize that extremity. Spider bites, the same thing. We need to bandage that, maybe use a tourniquet. If we are good at doing tourniquets, we need to be competent to apply a tourniquet. And then cold compresses to cause vasoconstriction to prevent the spread of the venom. And here is a brown recluse spider bite. That is necrotic tissue after about 24 hours after a bite. Lightning injuries. There is a very good article to read about what can happen with the patient's body if they are struck by lightning. It can affect the central nervous system and it can cause cardiac arrest. So when it goes to ground, so to speak, when the lightning goes through that patient, it will exit out of their extremity that is on the ground. So you will see an entry burn probably and an exit burn, and you can kind of guesstimate what internal organs might have been impacted as that lightning went through their body to exit out their foot. So skeletal muscle damage is very possible as well. You're going to be looking for elevated myoglobin, elevated CK, potassium, increased BUN and creatinine, and they are a potential for acute renal failure. Altitude-related illnesses. So that's when patients are hiking or skiing or doing things above 5,000 feet. There's lowered levels of oxygen, and so the priority treatment is going to be administering oxygen and getting them down to a lower altitude as quickly as possible. You can get acute mountain sickness, high altitude cerebral edema, so that's where your brain cells are accumulating fluid. High altitude pulmonary edema, your lungs are filling up with fluid. So we need to get these patients down to a lower elevation and give them oxygen. One of the things that we can give them is something called acetazolamide. You may hear it referred to as Diamox. And what it does, it induces metabolic acidosis. And when you have metabolic acidosis, your body increases its respiratory rate to compensate for that. And that helps this person who quite frequently may not be breathing rapidly enough to get in enough oxygen, because these altitude-related illnesses make them very sleepy and stuporous and maybe even unconscious. So what this Diamox does is acetazolamide is it increases their respiratory rate to raise their pH. And the last one we're going to talk about is a near drowning event, and here's a link to an article for that. You come upon a patient who appears to have drowned or is in a near drowning situation. We need to get them obviously out of the water. We want to maintain our C-spine stabilization as we get them out of the water so that we don't cause any damage if they do have a C-spine fracture, for example. We need to lay them on their side in the rescue position and keep their spine, again, as stable as possible. Do CPR, maintain airway, and get them to the emergency room so that they can be treated.